This is CACNETS. This is CACNETS. I'm Nan. I'm moderating the meeting today with Susan. And we have with us today Dr. Jaydira del Rivero, who heads the Rare Tumor Clinic at NIH. She's going to speak to us today about clinical trials, both the one that she runs and other opportunities for neuroendocrine patients at NIH. Dr. Del Rivero is both an oncologist and an endocrinologist. She is a specialist in all rare tumors. And I do have a small, she is the physician scientist in the developmental therapeutics branch at NIH and the principal investigator of the natural history study for neuroendocrine neoplasm and adrenocortical cancers. She has been with NIH for, I think, maybe 5 years, Dr. Del Rivero. Not sure if it's been more than that prior to that.
Yeah, it's been longer than that. I would say altogether with my 2 fellowships that I did at the NIH, I would say longer than that, closer than 8 or 9 years, I would say.
Okay, and prior to that, she did a specialty, not exactly sure what it was called, a fellowship with Dr. Wolin, who is one of the nationally known neuroendocrine specialists. He's now at Mount Sinai Hospital, but that was at Montefiore, I believe, where you did your specialty training there. She is originally from Mexico and got her medical degree in Mexico at the University of Veracruz. And she has a very close relationship with our support group. Many of us in the group have participated in her natural history study. And we're looking forward to hearing from you, Dr. Del Rivero.
Hi, thank you so much for the introduction. And it is a pleasure and an honor to be here with you all. And one subject I want to discuss with you is about clinical trials in neuroendocrine tumors. Mrs. Furman, can you see my slides? I just want to make sure.
Yes, we can. The first one is up.
Okay, perfect. And I know that you have had some other speakers in the past, and some of the other speakers may have discussed with you about the current clinical and treatment options for neuroendocrine tumors. And now I'm going to discuss about the clinical trials available for neuroendocrine tumors. Just as a reminder, what are neuroendocrine tumors? Neuroendocrine tumors arises from the neuroendocrine cells, which are localized anywhere in the body, even in the skin. We have also neuroendocrine cells in the skin. Based on the location, and I think that's important as well to learn and understand, based on the location, they may have different clinical manifestations. Approximately 60% of all neuroendocrine tumors are non-functional, meaning they don't secrete any hormones, but approximately 40% of neuroendocrine tumors may be functional, and depending on the location, may have a different hormone that they produce, and based on that, they may have a different clinical manifestations and presentations. Here, in this picture, I know you see a lot of names, and I just wanted to emphasize that based on where they are localized, you can see that they can produce a very specific hormones, and based on that, they may have also different clinical manifestations. For example, the pancreas can secrete different hormones, and as well, based on the locations, as I say, they may have different clinical manifestations. I don't want to go into detail about that, but I do have to say and mention that about 3 weeks ago, we have a conference with CACNETS, and I have to say that there is a whole video information about the management of neuroendocrine tumors with excess of hormone. And also, I have to say, I'm very proud that it's also available in Spanish as well to reach out a greater community. Something that I want to also discuss here is about the classification and grading of neuroendocrine neoplasia. I understand this. Hello? Okay. I understand this could be quite confusing sometimes in terms of when it's well differentiated versus poorly differentiated neuroendocrine tumors. What we know now is that there are different terminology, a category for the well differentiated neuroendocrine tumors. In the past, we used to say that all grade 2, they were poorly differentiated, but now we know that there are 3 different grades of neuroendocrine tumors that are well differentiated. And as you know, the well differentiated may have a more slow growth compared to the poorly differentiated. The poorly differentiated, I always want to make the difference between neuroendocrine tumor, which is well differentiated, versus neuroendocrine carcinoma, so which is poorly differentiated. Also, something that I'm sure you have discussed here in this group is about the Ki67. So what is the Ki67? So the Ki67 is a proliferation index, is how we are able to look at the proliferation of the cells under the microscope. If it's less than 3%, we know it's well differentiated grade 1 neuroendocrine tumors. If it's 3 to 20%, we say it's grade 2. Anything greater than 20%, it can either be a well differentiated grade 3 neuroendocrine tumors or more poorly differentiated neuroendocrine carcinoma. But usually this number, or what we call the Ki67, is usually, we see a higher, much higher number, greater than 50, 60%. It's something to keep in mind as well. So I know that, I think something that I want to mention is that currently, I think we are in a very exciting times because we have a lot of researchers that they have an interest on neuroendocrine tumors. They want to develop more effective therapies for neuroendocrine tumors. And again, I have to say that none of that could have been done because of all what you're all doing as a patient advocacy. You are bringing awareness. Even this year at the GI ASCO meeting, which is the main meeting for oncology, so the gastrointestinal tract, they have a session specific for neuroendocrine tumors. And I think that that has been possible because of all of the efforts that the patient community are doing, like you, CACNETS, and so forth. So even though in the last 20 years, there has been various different therapies of advanced neuroendocrine tumors, there's still room for improvement. And that's where I'm going to discuss about clinical trials. And again, I can, if there is time at the end for more questions, I can definitely describe what is my practice and what I do with different neuroendocrine tumors based on the available treatment options. So what are clinical trials? Clinical trials are research studies that test how well new medical approaches work in people. So these studies find better ways to prevent, screen, or diagnose and even treat a disease. So this goal of the clinical trials is to determine as well whether this treatment is safe and effective, and then eventually could lead to the approval by the Food and Drug Administration. And also that clinical trials also help us to compare new treatments with treatments that has been already approved of available to determine which one is better. Now, these are the phases of clinical trial, and I'm happy to answer any more questions at the end, but something just to understand about clinical trials is that there are different phases. And based on the phases, it has a specific goal. For example, phase 1 clinical trials, the main goal of the phase 1 is to determine the safety of the drug. If the drug is safe, what is the dose of the drug that can be, that is safe in humans to then move into the phase 2 study? It's mainly safety, and that's important. Phase 2 study is once you have a drug, we wanted to determine if it's efficacious. Once in the phase 1, we determine what is the best dose to move to the phase 2, then we have a study to determine what is efficacy. Phase 3 is given in a larger group of people, confirm the efficacy, and at the same time, it helps us to compare what is with other standard options that we have available. And then phase 4 is another phase that is much more longitudinal kind of a study where the FDA is still monitoring all of the approved agents available. So now let's discuss about ongoing clinical trials for patients with well-differentiated neuroendocrine tumors. And the first one that I want to discuss with you is what we call the Nether-2 study. So the NETHER-2 study is to evaluate the efficacy and safety of Lutathera. As we all know, Lutathera is an option for neuroendocrine tumors, well differentiated or intermediate differentiated neuroendocrine tumors that express the somatostatin receptors. And how do we know that? Is when we do the gallium dotted scan. Whenever we do the gallium dotted scan, we see the pictures, we see that the tumor slides out. That means that there is these somatostatin receptors on the surface of the cells, and because of that, they may be eligible for this treatment, which is the Lutathera. But the previous study that led the approval of Lutathera included patients with Ki67 less than 10%. Now, we wanted to know with this study, which is a multi-center international study, wanted to see if Lutathera is effective and can be used as a first line for patients with gastric and pancreatic neuroendocrine tumors with a Ki67 greater than 10%, but less than 55%. And one of the endpoints of this study is to determine if by given this treatment in patients with higher grade neuroendocrine tumors, could that help stabilize the tumor, the same to what we see on the NETHER-1 study that led to the approval of Lutathera. The second study that I want to discuss with you is a COMPETE study. So this study is a phase 3 study that determines the efficacy and safety of Lutathera in patients with gastric and pancreatic neuroendocrine tumors. So the main question for this trial is, could we use Lutathera as a first line? So we know that the everolimus is one of the treatment that has been approved. We know that other sunitinib has been approved, but could we use Lutathera as a first line? And that's something, this is the question that with this study, hopefully that can be answered. And this patient is, the cohort of patients that is included on this study is for patients that have a gallium positive scan. They're mainly not functioning gastric and pancreas neuroendocrine tumors. And that's basically, they're going to divide the patients whether they're going to receive Lutathera or everolimus. It's an ongoing study. There are about 9 centers in the United States that is available, and we discuss how you can have access to these clinical trials. And the primary endpoint of the study, as well as the previous study, is like, could this treatment also stabilize the growth of the tumor? Now, in terms of other studies, there is a phase 2 study of the LOT3 study in combination with Lutathera. As we all know, the LOT3 study is given for those 4 functional carcinoid tumors. So the tumors that produces excess of serotonin. And the LOT3 study blocks that excess of serotonin. And because of that, the symptoms related to carcinoid syndrome, like diarrhea, tends to improve with this treatment. Now, the question is, if you give the combination with Lutathera, could you make this treatment more efficacious? And the reason why is because there is some investigators that they think that the LOT3 can help also to decrease the growth of the tumor. So Dr. Shahan, who is the PI of the study, Aman Shahan, wants to determine if the combination could be better than single agent. And that's something that is an ongoing study as well. And one of the questions that he would like to answer as well is, with this treatment, can that help patients to stabilize the tumors and slow the growth? So now let's talk about other treatment options. So let's discuss about tyrosine kinase. I don't know if you ever heard about tyrosine kinase, but tyrosine kinase is a group of drugs that basically blocks the blood vessel supplies going to the tumor. One of them is cabozantinib. So and there is a study led by Dr. Jennifer Chan. She's a Dana-Farber, but it's also a multi-center study. There is many centers in here, and even in this area, Hopkins have it, and I believe also UPenn have the study open as well. And this study is to divide the patients whether they receive cabozantinib or placebo. However, something that I want to tell you that is important to mention is that even if you get the placebo and we see progression, you still will be able to get the drug. These patients include pancreas neuroendocrine tumors, as well as carcinoid tumors or small bowel neuroendocrine tumors. And the goal of this study is to determine if cabozantinib can be approved by the FDA, so that way there is another treatment option available for neuroendocrine tumors. So, and another question that I usually have with patients is like, what is the role of immunotherapy for neuroendocrine tumors? And what we know now is that single dose immunotherapy may not be as effective. We haven't seen single dose immunotherapy to have the response that we wanted to see. So now what a lot of investigators are doing and researchers and physicians is doing combination treatments. Maybe combination with other agents could be effective and enhance the immune system for this immunotherapy to have some activity. And cabozantinib is known as well to, once it blocks the blood vessel, there is some immune response. And by having this immune response, maybe immunotherapy could be more effective as well. We have seen this in other tumor types like bladder cancer. Dr. Kimberly Perez at Dana-Farber has the study of combination cabozantinib with nivolumab, which is a type of immunotherapy for carcinoma tumors. So mainly for patients that have small bowel neuroendocrine tumors that produces excess serotonin or symptomatic tumors. And she first wanted to determine, if the combination is safe. And then once it's established, she wanted to treat patients with carcinoma tumors as well. And the primary, and the answer that they want to, what is the endpoint of the study is that they wanted to determine if the combination could shrink the tumors. And that's one of the studies that Dr. Perez is running. So, and there is another study by Jonathan Strathberg, Dr. Jonathan Strathberg. I'm sure you know Dr. Strathberg. He led all the studies who then eventually led to the approval of Lutathera here in the United States. So he was the one he's the first author on the paper that led the approval for Lutathera for gastric and pancreas neuroendocrine tumors. And he also have a study of combination lenvatinib with another type of immunotherapy. Lenvatinib is another tyrosine kinase inhibitor as well. Again, the tyrosine kinase are drugs that blocks the blood vessel supply. And the same rationale that I explained earlier, he's now combining with another type of immunotherapy as well. And this is for all well-differentiated neuroendocrine tumors, mainly of the GI tract, and is available, and he's actually approved in patients as well. So one other study that I want to mention here, because when I talk to patients, I think that there is not a lot of information for lung neuroendocrine tumors. And I think that one of the frustration that I have heard from patients that have lung neuroendocrine tumors, they have positive Gallian scan or dotted scan. And despite having a positive dotted scan, they are not eligible to get Lutathera, and insurance are unable to pay for that, for the treatment. So, and I can understand that that can be very frustrating for patients, and there is now open for recruitment just a month ago is a phase 2 study with Lutathera for those patients that have a Gallian scan positive for bronchial neuroendocrine tumors. They're going to divide the patients to either receive Lutathera or everolimus. Everolimus is approved for bronchial neuroendocrine tumors. And the question that I want to answer is to determine if by giving this treatment, could that stabilize the tumor? But at the same time, if we find the same efficacy that we have seen with the GI and pancreas neuroendocrine tumors, that could also lead to the FDA approval, and it will be available for patients as well. So now, what is the science? Where is the science moving forward? And I think you all know that PRRT is a good treatment. It's an excellent treatment for neuroendocrine tumors. It stabilizes the tumor as well. But one of the questions that usually comes with Lutathera is, can we make Lutathera more effective? Because we know that even Lutathera helps to stabilize the growth of the tumor. Sometimes we don't see as much shrinking. That being said, we have seen patients that have exceptional response to PRRT in which the tumor definitely shrinks. But one of the questions is like, could we make Lutathera more effective? And that's where these different agents plays a role. And I will explain to you what this means. Lutathera, as you know, is a type of radiation. What radiation do on the cell is breaks the DNA. So Lutathera being a type of radiation, they damage the DNA and there is break on the DNA. However, when the body senses that, our own body is trying to repair that damage. And because of that, sometimes when they trying to repair this damage, sometimes we have DNA that is not a very good DNA. And then what happened in that situation, that's what some researchers say, well, maybe the treatment is no longer effective, or maybe there's this specific treatment may be resistant as well to the tumors. And because of that, we're trying to understand more. If we block that repair, could we then make effective and avoid that other issues later on of no response or not having resistance to the treatments? And I think this is a very exciting time for this, because based on the information that we know with other tumor types, it seems that by giving this type of treatment that blocks that repair, it can make other radiation treatments more effective. And I'm going to mention the ones that are available. Trypin, Dr. Shahan is the PI on that study. Here at the NIH, we have the elaborate study in combination with Lutathera. And Dr. Shahan actually just opened another study with the posertib in combination with PRRT. And this is the phase 1 study of Trypin with Lutathera. And the reason why is because first we need to determine if the combination is safe and what will be the best dose when we give in the combination. So that's the reason why there is a phase 1 study. He's very optimistic about the trial, and if you want more information, I'm happy to provide any of his contact information as well. So one other question that I have is about the alpha emitters. So, and that's kind of like new generation PRRT. And that's something that we wanted to learn more about it, some exciting results. And there is an ongoing phase 1 study with Dr. Delpasant of these alpha emitters, ductamtate, and patients that have positive Gallian skin and well-differentiated neuroendocrine tumors. So he gives 3 cycles every 2 months. And one thing, because it's a phase 1 study, he's trying to determine what is the best dose to then move it to the phase 2 study. But I think that this is very exciting to learn what are the results of this study. And I think that's an ongoing discussion that we have also with patients as well. Another study that I want to mention to you, and UPenn has a study, Dr. Sulen, and I believe some of you also are familiar with Dr. Sulen, is about embolization for liver metastases related to neuroendocrine tumors. As we know, neuroendocrine tumors likes to go to the liver, and sometimes they stay in the liver and no other places. And sometimes whenever we discuss neuroendocrine tumors, and I think you have this discussion as well, the neuroendocrine tumors need to be discussed with a multidisciplinary team. And the reason why is because the treatment of neuroendocrine tumors is very personalized. It's not like one size fits all. Whatever we think is effective for one patient or will be a good option for one patient may not be the best for the other patient. So I think it's important that we discuss in a multidisciplinary team to determine, what are the treatment options. And the reason why is because these neuroendocrine tumors are very diverse. And me as an oncologist that treat neuroendocrine tumors, I need to know what is the somatostatin expression, what is the bulk of disease, is the tumor is growing slow or the tumor is growing more fast, and then if it's not somatostatin receptor avidity, what other options we have. And that's the reason why we have to discuss with a multidisciplinary team. Now, this is a study that is led by Dr. Solent, is for those patients that have neuroendocrine tumors that mainly localized in the liver. And he gives different type of treatments, either a blunt embolization, basically goes to the hepatic artery, because that's where the tumor gets the food from the hepatic artery, goes to the hepatic artery. And the whole idea is to block or burn that vessel that is feeding the tumor. And it could be a blunt embolization or a chemoembolization. I have to say that the eludent BITS embolization is a group that was closed because they saw more infections with this group. I still don't know the results of the blunt embolization versus chemoembolization. I have to say that what we do mainly at the NIH is blunt embolization. So now, what is ongoing clinical trials for poorly differentiated neuroendocrine carcinoma? So we discussed, we have neuroendocrine tumors and then we have neuroendocrine carcinomas. And Dr. Das is leading a trial of chemotherapy in combination with a drug that also blocks that DNA repair. So I think a lot of the research is how we can block DNA repair, so that way we can make the treatment more effective. And chemotherapy, like radiation, also damage the DNA. So this is in combination with another treatment for patients that have poorly differentiated neuroendocrine carcinomas. And there is another treatment by Dr. Tesfaye is combination immunotherapy. So I think there is a role for immunotherapy, or maybe a role for immunotherapy for those poorly differentiated neuroendocrine tumors. And that's combination with two different immunotherapy plus cabozantinib, as I explained earlier, the role of cabozantinib and immunotherapy. And that's something that this is a treatment that is ongoing. And the question that I want to answer is, by doing this treatment, could that shrink the tumors? And this is an ongoing study as well. So there are more studies about more treatment, clinical trials available for neuroendocrine carcinomas, and we can discuss about clinicaltrials.gov. So now we're going to discuss what we have available at the NIH, and I'm glad that Dr. Sadowski is here with me, because she can also discuss after my talk what is doing in terms of her research as well. But so one of the, I think as Mrs. Furman discussed earlier, I am board certified in endocrinology and oncology. Before I was an oncologist, my primary practice was as an endocrinologist, and I was seeing these different neuroendocrine tumors. And I felt like at that time, it's like we need more treatment options. What is the challenges? I felt that those neuroendocrine tumors doesn't have as much recognition as other tumor types. And I felt like, well, this is maybe an area that we can make a difference. And as we know, there are only few FDA approved agents compared to other tumor types. But however, we don't know when or what combination therapeutic approach we should use. It's still a question that we want to answer. We don't know how long should treatment be continued. For example, the combination capecitabine temozolomide. Some oncologists may recommend only for less than a year. So others, they may recommend longer. So I think that's a question that we want to answer as well. And also, what's the group of patients a particular treatment option should be used? That's another question that we wanted to address as well. And of course, we wanted to understand as well the role of immunotherapy and neuroendocrine carcinoma. So there is a lot of, this is just a few questions, but there's so many unanswered questions in the field of neuroendocrine tumors. So, and then one of the things that we're doing at the NIH, and we are fortunate, I'm fortunate to be working with other researchers that also have an interest in neuroendocrine tumors. But one of the things that we want to do, or we're currently doing to answer some of these questions, is that to comprehensively develop a classification system that incorporates tumor clinical stage, genomics, epigenetic alterations, gene expression profile that could serve to better define the biology of neuroendocrine tumors. At the same time, to hopefully establish correlations with clinical outcomes, as well with this information to develop effective therapies. One thing that, and also we wanted to acknowledge what are the challenges as well. I think a lot of patients with neuroendocrine tumors and their families, they face unique challenges. Number one, it takes a long time sometimes for diagnosis. And when they are diagnosed, they're already on advanced stage. So a lot of centers, they have limited experience for these tumors. And sometimes patients often has to search for experts and potentially requiring traveling outside of the home region. As we discussed, there is no standardized treatment guidance. So we know the treatments that can be given for depending on the size of neuroendocrine tumors. But as I discussed earlier, sometimes we discuss what would be the very first treatment option. Lutathera seems to be the one, but again, I think that this is an ongoing discussion as well. And sometimes patients feel isolated as well, because they're not, it's considered a rare cancer, and sometimes patients feel isolated. And we feel that by developing an accessible national and international patient engagement network for net research and patient care with advocacy and support groups, and that's when the advocacy plays a very important role, like CACNETS and CACNETS and so forth, will hopefully address the patient needs and then increase access to patients for research and at the same time for treatment options. At the same time, net researchers also has some challenges as well, because sometimes being these rare tumors, sometimes it can take a long time to recruit patients into the clinical trials. as we discussed, multidisciplinary care is needed for patients with neuroendocrine tumors as well. Sometimes there are silos between teams, and sometimes teams of medical teams, they may not communicate with each other, and that can also create these silos that limit efficiency as well as clinical trials. And one thing that is always, that's kind of like has been a challenge for in neuroendocrine tumors is that there are very limited neuroendocrine tumor cell lines that for drug testing. There is no other clinical studies, other preclinical models that could help us to develop better treatments. And that's kind of like one of the struggles that we have as a researcher, and to be able to develop more preclinical models to then optimize what would be or personalize the treatment options for neuroendocrine tumors. And at the same time, research can be challenging because there is less resources as well. So, and we feel that collaborative, well-funded research network for neuroendocrine tumors could promote or will promote development of new therapies and standards for patient care. And that's where the rare tumor study or natural history study that we have at the NIH is important. And this is all within the rare tumor initiative that is at the NCI. I am, as we discussed earlier, I lead the natural history study for of children and adults with neuroendocrine tumors. So we do a very comprehensive evaluation. We collect very comprehensive data in terms of demographic, clinical characteristics, a response or lack of certain therapeutic interventions. We wanted to determine as well by certain treatment how long the response is and so forth. So we wanted to really understand more about these neuroendocrine tumors from the clinical aspect, molecular aspect, as well as social aspect, to help us understand if we can develop better treatments for neuroendocrine tumors. It is a longitudinal study, meaning that we study patients long-term. Patients doesn't need to come to the NIH. The evaluation can be done remotely. We also, depending of what is the clinical manifestation of these neuroendocrine tumors, less than 10% may have may be familial. And then if that's the case, we also wanted to study patients that have also the germline mutations that may not necessarily has the disease. We also do clinical and laboratory evaluations for patients that comes to the NIH as well. We're trying to understand, by having this diagnosis or living with this diagnosis, how does affect me in the socioeconomic level, on fatigue or depression. So we wanted to understand that as well. We do a very comprehensive molecular profile as well in the tumor. And based on what we found in the tumor, we then do a more extensive analysis in the blood. And the idea of doing this is to be able to develop new therapies and endpoints for clinical trials and screening guidelines. So this is how patients comes to the NIH. Either the physician or the participant refer to us, and we ask for all the records and scans, pathology. After we have all the information, then we decide if the patient can be eligible for other clinical trial within the NIH, or they can be enrolled on the neuroendocrine tumor subprotocol and then followed in long term. Other studies that we have available at the NIH is a natural history for von Hippel-Lando. As I discussed earlier, less than 10% of neuroendocrine tumors is familial. And Dr. Nullable, who is an endocrine surgeon and colleague of Dr. Sadowski, has this natural history study to better understand the pancreas neuroendocrine tumors associated with VHL. This is also a longitudinal study as well. And now we discuss about two natural history studies that we have. And so what are the treatments that we have available at the NIH? So the first treatment study that I want to discuss is a combination phase 1/2 study of combination olaparib with Lutathera for gastric and pancreas neuroendocrine tumors. As I discussed earlier, olaparib blocks DNA repair, and we wanted to the question that we want to answer is,
right.
Oh, that was fast.
We are going to send your doctor's written report. This is your CD.
Oh, great.
Okay.
And
And that's your other one.
oh, wonderful.
All right.
Thank you.
You have a nice weekend.
You too.
Thank
Where, I'm sorry, I need to use the bathroom again.
So if you, on your way out,
Uh-huh.
you're gonna go down the hall to the left.
This is Carmen's right stop.
Oh, okay, great.
Okay.
Thanks so much.
You're welcome.
Thank you. Everyone, please mute except Dr. Del Rivero. Thank you.
Great, thank you.
Thank you, Barry.
Okay, thank you. Okay, and what other treatment do we have available at the NIH? We have another treatment, it's called Valsutefand, and this is a treatment for patients that have pheochromocytomas and paragangliomas, as well as pancreas, neuroendocrine tumors. The idea of this drug, it was recently, has an accelerated approval by the FDA for patients that have kidney cancer in relationship with VHL. And when they did the study, they only enrolled patients with VHL, but as you know, VHL, von Hippel-Lindau, also has other clinical manifestations such as pancreas, neuroendocrine, pheochromocytomas, and other clinical manifestations associated with VHL. And they found that by using this agent, then the other tumors also shrink. Okay. Mr. Lepstein, maybe you can mute.
Yeah, I'm trying to find out who it is.
That's okay. Thank you so much. So then it's a treatment that is soon to be available at the NIH. These patients this protocol include patients with pheochromocytomas as well as pancreas neuroendocrine tumors. Another study, another natural history study that we have available at the NIH is the natural history for pheochromocytomas and paragangliomas led by Dr. Patzak. It's also, as I discussed earlier, is a natural history study. These pheochromocytomas and paragangliomas are also known to be a type of neuroendocrine tumors. They're extremely rare. And there are very limited treatment options in the metastatic setting. It was until 2 years ago that we have the first treatment option approved for pheochromocytomas and paragangliomas. However, that's with an MIBG treatment. However, not every patient is eligible. I will say that less than 45% of patients may be eligible for that treatment. So, but one thing that we know about these pheochromocytomas and paragangliomas is similarly to other neuroendocrine tumors, they also express somatostatin receptor in more than 90% of the tumors. And I think you're already very familiar, the difference, what was the Octra scan and now the difference with the gallium dotatate scan. And you can see, that with the gallium dotatate scan, we can see the lesions very well differentiated. And I think that's an imaging study that has definitely evolved and the treatment of treatment algorithms for neuroendocrine tumors. And we have at the NIH study, a Lutathera study for pheochromocytomas and paragangliomas. And the question that we want to answer in this study is, by giving Lutathera for patients with metastatic pheopara, can they also stabilize the disease? But one thing about this tumor type is they produce excess of catecholamines or metanephrines or adrenaline. And we also wanted to understand, by giving this treatment, can that also lower the hormone excess that can then improve the quality of life? And that's another question that we have. I'm also fortunate to lead this trial with Dr. Kim Perez. This is a trial of temozolomide in combination with olaparib. So just to let you know, temozolomide is also a chemotherapy, very similar to what I said before. Temozolomide is a chemotherapy that damages DNA and cause DNA breaks. So by doing that, could the combination be more effective? And that's the question that we want to answer. And we will have this available soon at the NIH. It was just recently approved by the IRB, so it should be any time that we will start screening patients. Again, this is a patient that is that I'm running with Dr. Perez. Now, how about clinical trials for neuroendocrine carcinoma? So I discussed with you what we have available for neuroendocrine tumors, what we have available for pheochromocytomas, and how about for the higher grade neuroendocrine carcinomas. And I'm working very closely with Dr. Thomas. Dr. Thomas is an expert in small cell lung cancer, and he had a study of lurbinectedin in combination with versasertib. And again, these are names, and those names can sometimes be complicated, but it's exactly the same rationale that I've been saying throughout the talk. It's a chemotherapy that is given that cause DNA damage, and then by giving a DNA repair blocker, could that be effective? And there are 2 cohorts of patients, one for small cell lung cancer and one for high-grade neuroendocrine carcinomas. And we just started accruing patients with high-grade neuroendocrine carcinoma about 4 weeks ago. I'm also working on another studies of first line for high-grade neuroendocrine carcinoma. I hope it will be available in the next 3 or 4 months, and I'm happy to give you an update once that's available. Again, one thing that I always want to discuss with you all is like, how can you have information about clinical trials? A way to do it is to go to clinicaltrials.gov. And usually, as you can see here, you can type the condition of the disease. You can also type what is the, if you know the investigator name, but only by typing the condition or disease, you will have a lot of information. And at the same time, if we're in the country, you want to find a clinical trial. And I think that's an information, a useful information for patients. One other tool that I strongly recommend is a 1-800-4-CANCER. And it's a website, but at the same time, you can always call as well, Monday to Friday. And it's a very, very useful information to know. And the reason why is because you call, they're very helpful. They can definitely tell you what is available in clinical trials, not necessarily at the NIH, but anywhere in the United States. They can also give you information about symptoms. They can also give you information about cancer prevention or risk factors, or, it's a very comprehensive tool. I think it's very helpful. Some of my patients that have gone there, when they say it's very helpful, they can obtain a lot of information about their cancer type. This is information that is here for you. Okay, this is my last slide. So I want to thank you all. And something that I want to say, it takes a village. This is a work that I'm not doing on my own. There is a lot of people involved here at the NIH that are trying to help to develop better treatments for neuroendocrine tumors. As you can see, this is just a few that we can mention here, but besides this, investigators, there are even more people behind them that are doing all the work. So as you can see, there are a lot of people that really want to make a difference in neuroendocrine tumors. I also want to give thanks to Dr. Shahan, Dr. Strothberg, Dr. Chen, Dr. Perez, Dr. Das, which they provide me the slides of their study to be able to share with you. And of course, more importantly, I want to thank all the patients without whom none of the studies would have been possible. And I'd like to end my slide with, or my talk, saying individually we're a drop and together we are an ocean. I think that this is something that if we get together, physicians, researchers, patient advocacy, I think we can definitely advance the science and develop better treatments for neuroendocrine tumors. As I say, if the neuroendocrine tumors has a recognition, a lot of that is because of patient advocacy. So I have to say, I have to thank you all for everything that you're doing, because without you, we wouldn't be where we are right now. So I really want to thank you all. Okay, that was the end of my slide. Oh, Mrs. Furman, I think you're muted.
Everyone, it was muted
That
during
is
the
very-
presentation. So what I would ask is, when you wish to speak, would you please unmute? Otherwise, please remain muted.
Dr. Del Rivero, we want to thank you very much for coming to speak with us today. You are a most collaborative physician, a good friend of CACNETS, and we appreciate all your time and willingness to share your knowledge and experience with us. There were a few questions that came in during the week.
And Mrs. Furman,
I'd like to know if you could answer.
yes, absolutely. And I'm here as long as you want me to be. But one favor, I just want to make sure that we welcome Dr. Sadowski, since she's here from the surgery oncology branch. She's research also focused on neuroendocrine tumors. And I want to make sure that if there are any questions that I cannot answer, that Dr. Sadowski can also be able to answer as well.
Excellent. Thank you very much. One question came in during the week. Is there a hematologist on the staff at NIH who could address questions, especially related to post-PRRT complications like MDS? And are there any clinical trials that are available for looking at MDS as a treatment? Yeah, okay.
Okay, well, thank you so much for the question. I really appreciate it. We don't have a researcher or a clinical trial that address PRRT related myelodysplastic syndrome. However, we do have specialists that all they do is study bone marrow failure, and myelodysplastic is one of them. So as PRRT may cause, and again, it's less than, right now what we know is 2 or 3% that can cause myelodysplastic syndrome over time. The same as PRRT, there are other agents that also cause exactly the same. So that's the reason why we do have an expert specialized on myelodysplastic syndrome. We don't have an expert that is specialized on PRRT related myelodysplastic syndrome. But I have to say that if that were to happen, which is very rare, this treated the same, and any person who is specialized on what we call bone marrow failure can definitely help in that situation. I don't know if that answered the question.
Thank you. Also, there's a study that I found on clinicaltrials.gov that's dealing with dual tracer PET imaging. Can you talk about that study?
Yeah, and maybe Dr. Sadowski, you want to start with that question, since that's, and it's something that I want to say and about Dr. Sadowski. So one of the things of her work, her research that she's doing is to understand more about somatostatin receptors and how that can be upregulated to then, be expression of these receptors to then be available for Lutathera treatment. So I will leave it as it is, and maybe Dr. Sadowski can talk more about that.
Yeah, hi. Hi, everyone. Thank you for inviting me, or Dr. Rivero recommending. So I'm one of the endocrine surgeons, or 2 endocrine surgeons at NIH, clinically operating on patients with pancreatic and GI neuroendocrine tumors. And my lab, as Dr. Rivero, focuses on de-differentiation of neuroendocrine tumors, tumor progression, basically, and then loss of SSTR2. There was a question just in the chat. We do know that over time, unfortunately, these tumors can actually vary in Ki67 and number of SSTR2 on the cells, and that makes it very hard, for patients, of course, for you all and us to treat. As to the imaging, so my background is I was part of the gallium dotatate first in-human study at the NIH. And when we brought it to the NIH in our gallium dotatate study, and I have moved on from that and hope to open soon for patient with what we call SSTR negative neuroendocrine tumors, which most of the time are high-grade tumors, but as you all know, even low-grade tumors can have lost. So what we try to do with multiple targets is to target different receptors on the cells, but also these studies with the radionuclides is to be able to give different types of killing activity into those tumor cells. And so there's multiple research in my own lab, and I work with the radionuclide facility, be it, as you know, gallium is a gamma radiation and have a different penetration into the tumors. And then there's new ones with alpha, like Dr. Del Rivero just showed, alpha emitters that have a different activity. Happy to answer any question, be it surgical or imaging related.
Yeah, thank you.
Is that dual tracer study one that is open now?
We don't have a dual tracer yet open at NIH. Which one are you referring to?
It's called dual tracer GA68 dotate and 18F FDG PET imaging in G2 and G3 gastropancreatic neuroendocrine.
Oh, in the sense of adding the FDG PET. So that allows us a lot to give, prognostic information when we combine, as we know, it's inversely correlated between the dotatate or the SSTR2 targeted imaging and the FDG PET are inversely correlated. So someone who has high uptake on gallium dotatate will have low uptake on FDG PET, and vice versa is true as well. And to make it difficult for all, every patient is different. And even a same patient can have multiple tumors with different uptakes on each of those two imaging tracer. So that's what we're trying to learn from.
Mhm.
Hmm.
Did I answer the
It's
question?
a very interesting concept.
Yeah.
Yeah, I think what you're saying, Dr. Sadowski, is that you would be able to trace tumors with different SSRTR, trace different receptor.
Correct. And
yeah,
FDG
okay.
PET has, as you all know,
Okay.
been widely used in oncology for many, many years and has shown to be prognostic in the sense the information we get from an FDG PET can allow a clinician to give, depending on which tumors we're talking about, give us information on the aggressiveness of the tumor. And those have been shown, be it for ACC, so the adrenal, be it our rare tumors, or be it breast cancer or any other cancer. And so we are trying to basically get more information as to how the SSTR2 targeted imaging can give prognostic information as well.
Great. Someone has asked whether large cell NET tumors, whether people with large cell NET tumors can participate in all of these trials.
Yes. For the high-grade neuroendocrine, because that's considered high-grade neuroendocrine carcinoma, large cell versus cell, yes, they are eligible for the study as well, for the upcoming study that I'm going to have as a first-line treatment. The answer is yes.
And what about the case in which a person had tumor surgically removed and is now considered cancer-free? Are there ways for that person to be enrolled in a study so that they can be monitored?
Yes. I mean, the whole idea of having the natural history study, as I say, it's a longitudinal study. We study patients over time, is to also study patients that don't necessarily, that they are cured from their neuroendocrine tumors, and at the same time, see if there is any, to determine when, if they were to recur. We usually say after 5 years, if there is no evidence of disease, we can say that the likelihood that this is going to be recur is less and less, but we still follow those patients up to 10 years. But I think that, yes, I mean, that's information that we want to gather as well, and to help us understand more about the biology of neuroendocrine tumors.
Okay, a couple more questions. Dr. Sadowski has answered some in the chat, but I just want it to be open for anyone who's not looking at the chat. A question about the Ki-67, can that change over time? Dr. Sadowski has said yes. Can you add anything to that?
Yeah, so we have seen, and it's unfortunate, patients that we've encountered or diagnosed. Many of you who are have well-differentiated tumors that we are able to perform surgery as a first-line therapy, can sometimes unfortunately recur or have metastases even at later stages, and then these metastases can have different Ki-67. And even patients where we followed over the years, and that goes back to the dual imaging tracer question, we follow with FDG PET as well at the same time. We can see even patients who have multiple liver metastases, that these over time can progress and have a increase in Ki-67 over time and lose the receptor over time. So we've seen that happen, unfortunately, and it can go both ways. So doing multiple liver biopsies can give information on the Ki-67 and help us guide then the best either still standard of care therapies that we have or enroll in certain trials.
Thank you. Someone has asked what type of NETs will be eligible for the trial for SSTR negative, and are lung NETs included in that?
I think they are, Dr. Del Rivero.
Dr. Sadowski, that's what you say about the SSRT negative. Is there is a trial that you're working for that?
Oh, that I'm working on so I'm hoping I'm currently at the stage of doing in vivo, so on mice studies, and hoping to bring a trial to that's what we work on at NCI to open these trials. And that would be without lung. For me, I'm focused on GI and pancreatic NET. So, but again, that's not open yet. That's in the works based on my preclinical lab research at NCI.
Okay, thank you for that. Another question, does PRP therapy raise the risk of transferring cancer cells to other areas not currently showing tumors? For example, to a shoulder being treated for rotator cuff injury.
Okay, Mrs. Furman, I'm so sorry. Could you repeat that question again? There was a little bit of cutoff in the middle.
Yeah, the question is, does PRP therapy raise the risk of transferring cancer cells to other areas not currently showing tumors?
Yeah, the answer is no. Yeah, we have not seen that. I mean, sometimes, I mean, I study another tumor called adrenocortical cancer, and sometimes with that, biopsy is not indicated because it can go to other places. Once you remove the needle, there's cancer cells in the needle, and if it goes everywhere after that, but we don't see that, you know, with neuroendocrine tumors. What do you think, Dr. Sadowski? I don't think PRT transfer can go to other places. Yeah.
So it's after PRT is the research is more recent, since this therapy has evolved and been approved recently. To our knowledge, it should not happen, and it's uncommon that the neuroendocrine tumor cells would happen or show up at other regions that were less familiar specific to this tumor. What is less known, and I suspect that is a little bit what this question refers to, if it can provoke or produce in the future secondary other types of tumor. Is that the question? So that I don't think we have a full answer yet. For now, it's not known to produce secondary, tumors related to the therapy.
I think the question is, like with PRT, can the neuroendocrine tumor cells can go to other places, can travel to
that I don't think is happening. In
so that was my question, and it was on platelet-rich platelet-rich plasma therapy. So when being treated, I have the stage 4 metastases, small intestine with metastases to the lymph nodes and to the liver. And my orthopedic was thinking about doing the PRP treatment, where they take the blood, spin it, and then re-inject it into the shoulder. The question was, since the cancer is in the bloodstream, is there a risk of, once we transfer it, spin it, and then transfer it to the shoulder, is there a risk of the tumor cells being introduced into the shoulder?
That's a very interesting question, and I have to say that I don't think that we have done that for neuroendocrine tumors to, that type of therapy. Dr. Sadowski, I know that you work in the branch with Dr. Rosenberg, but sometimes what they do is they kind of like remove the tumor and they try to kind of like develop this type of immunotherapy. But I don't think that that's something that I have to say I don't know about that, but I would like to learn more about that. What do you think, Dr. Sadowski?
A good question, and I don't think I have an answer, as I don't know. I haven't performed this type of treatment.
But it will be good to learn about that. I don't know, like if this is in the setting of a clinical trial. I don't know who asked the question, but I don't know if this was the same as
I had asked the question, like I say, with my orthopedic, the question is obviously the PRP is still not approved, so it's considered experimental. But when I brought up the fact that I have the neuroendocrine tumors and the fact that it has metastasized, it would make sense to believe that since the cells are in the bloodstream, if we're taking the cells from the blood, even if we're spinning it and then reintroducing it into another portion of the body, which in my case would be my shoulder, which has no metastases currently, am I at a higher risk of having metastases showing up in the shoulder? So that's I don't know.
I now I understand your question. Thank you so much for clarifying. And initially when I said PRP, I thought we were talking about PRT.
Yeah, same here. I misunderstood.
So plasma rich, yeah, I kind of like I understand. Yes, and the reason why your orthopedics is doing that is because you most likely has an injury in that area. They wanted to make. I don't think that will happen. I mean, that's something that I don't think has been known to, like, if it's injected in the area, can cancer cells appear in that area? I don't think that's something that we know can happen. I hope that answered your question, and my apologies. I saw PRT.
We're really running out of time, but there's one more question that I think you might not have heard before. Since this type of cancer is considered to be rare, how reliable is the pathology report? And is a second opinion warranted?
Yes, I can answer, and then maybe Dr. Lasky can add anything more. But yes, I think, in my personal opinion, I think it's important that the pathology is being reviewed by someone who knows neuroendocrine tumors. And the reason why is because I think now is more universal that people are knowing, more pathologists are learning about the new classification. But even like 2 years ago, sometimes they were calling some of the tumors grade 2, and they were calling the name of neuroendocrine carcinoma. And then fortunately, we do have at the NIH good pathologists, excellent pathologists that know neuroendocrine tumors that really know the difference between grade 1, grade 2, and grade 3. I think one thing is about grading. I think it's very important to have a pathology who knows about the grading of neuroendocrine tumors and how they are labeled. And I think that, yes, I personally, if you're comfortable with the diagnosis, it's okay to send your pathology with somebody, so in a center that they are very familiar with neuroendocrine tumors. One thing that sometimes I've been asked is about, if can I do another biopsy, or can that change, or maybe I have another biopsy and then you're not convinced about the findings. But usually well-differentiated neuroendocrine tumors are very, very indolent, very slow growing. So if you're having these tumors for 5, 6, 7 years, I doubt that the Ks67 will change that much. So that's one of the things, but that I think is important to know. But I agree that a pathologist who has an expertise in neuroendocrine tumors should look into the microscope and read the slides.
I agree with
Thank
that.
you.
I think it's very important. We, prior to surgery, if there's any doubt, are happy to review any pathology reports that are needed. And I think a second opinion in any form is always important, and we are happy to provide if we can.
Right. And I think that's important also to know, right, Dr. Soski, because that can definitely help us establish what is the treatment, surgeries or liver-directed therapies, or, yeah.
And we make that decision at NIH. Things are discussed in a format that is at university known as Tumor Board, where we have radiologists, we have oncologists, Dr. Del Rivero, we have our endocrinologist. She covers both hats, but additional endocrinologists. We have, the IR specialists who do liver-directed therapies. We have us, the surgeons, and we do work also. I myself do all types of endocrine surgery, be it adrenal, neck, pancreas, and GI net, but we do have very good hepatic surgeons and hepatobiliary surgeons that we work together with, and on the larger cases that need addressed. So that can be helpful. A website should be up soon that connects. We are planning to have what we call a net focus group at NIH, linking all us from basic research to clinicians, where you could then find all the doctors and researchers and trials all together. So hopefully that will help in the future.
Yeah, I'm very excited about that.
Yeah.
Because, one thing that we,
One last,
yeah. Yes, of course,
I'm
we're
sorry.
here, Mrs. Furman. I'm here as long as you want me to be.
I understand, but we do need to close, but I have one more question, and that is, can you please either put into the chat or specifically tell us how to contact you and or Dr. Ikra Ahmad for
Right.
getting into the longitudinal study?
Right.
We,
Yes.
we always tell people in the group, but this is from the horse's mouth, so that would be great.
Yeah. Yes, absolutely. And I can give you my email, and the slides has my emails and my direct contact information as well. I can put the email now. I don't know Ikra's email. So Ikra is a research nurse who's coordinating the natural history study for neuroendocrine tumors. So she's the one that is, communicate, and she's the one helping, making sure that we get all the information here. But for now, I can give my email, and I can definitely put you in touch with Ikra as well.
Actually, I have Ikra Ahmad's email address, so I will put it
Oh, you
in.
do? Awesome.
I've got it.
Awesome.
Thank you
Yeah.
very much for coming to both you and Dr. Sadowski. This has been very informative, and if anybody has further questions, they can get in touch with you.
Absolutely.
Happy
Anytime.
to. Please
Yeah.
contact us.
Yes, contact anytime. Okay. Thank you so much.